Hello students, today I am talking about the psychotropic drugs part 2. In the part 1 I have discussed about the anti-anxiety drugs, and here I will discuss about the antidepressant drugs. Psychotropic drugs, we have to understand uh, how these drugs actually working. And in this case, we have to understand very well that most of these drugs are working on the functions and physiology of the neurotransmitters in the brain. And they are altering, or they are changing the physiological behavior of the neurotransmitters, that how neurotransmitters are synthesized, what is the rate of synthesis, what is the rate of release, what is the rate of metabolism of them, and like that they are changing the normal or abnormal course of the neurotransmitter functions. So that we have to understand before we discuss about the antidepressant drugs. Here I'll just brush up you with the little information about the neurotransmitter and its functioning. Already you have understood it before in the neurohumoral transmission topic. So whenever the neurotransmitter releases, these neurotransmitter releases and causing the depolarization on the second neuron, or the when they release into synaptic cleft, they get bind with the other neuron or the second neuron in the synapse, and the effect will be created on that neuron. So what is happening here, whenever the depolarization happens, the action potential generates, right? And this action potential results out the release of certain chemicals. Here the release of the chemical in the synaptic cleft is happening because of the calcium facilitated release. This is a calcium facilitated release there. And when this chemical releases in the synapse between two neurons, the potential difference get altered at the second neuron, means the other neuron. The change is called as postsynaptic potential, maybe either depolarizing or hyperpolarizing. You know very well about this. A depolarizing postsynaptic potential is called an excitatory postsynaptic potential, represented as EPSP. That usually, is greater depolarizing action potential produced. In other hand, hyperpolarizing potential, which we also call it as inhibitory postsynaptic potential, or IPSP, is produced. It will inhibit the formation of depolarizing action potential. So one way you can find excitatory potential generates, and another way inhibitory potential generates. It depends what kind of neurotransmitters are releasing. Here, if we understand that this physiology, what I have explained you, how the drugs are going to impact this particular system. So here there are the drugs which are either affecting that system by increasing the neurotransmission or by decreasing the neurotransmission. Right. First, we'll see how the drugs acts by increasing the neurotransmission. So here, number one, increasing the rate of transmitter synthesis. As I told you in beginning, they are changing the rate of transmitter synthesis. So here they are increasing it. Increasing the rate of transmitter release. Same way, the release of transmitter also increases. Prolonging the time the transmitter is on the synapse or is in the synapse, right? So that also is, they are acting the attachment timing. So like that, there are three ways. Either synthesis can be increased, release can be increased, binding can be increased, or any of these things in combination can also happen. Another is diminished responses, how they decrease the responses. So in this, decreasing synthesis of transmitter, increasing transmitter metabolism, means transmitter is getting more and more metabolized, so they'll not be there in the system for a long time in the active form. Promoting an increased neuronal uptake or blocking access of the transmitter to its receptor. So these are the methods by which the transmitter action which has been produced can be diminished or been taken off. Just to remind you, I have just noted down some of the neurotransmitters here. Yeah, just I'll name for you. Acetylcholine, dopamine, norepinephrine, epinephrine, serotonin. Other than that, we have amino acid transmitters, which is called as GABA, which is one of the major inhibitory neurotransmitter. And in case of the mental excitability, GABA is one of the very, very important target. Glycine, vasopressin, and oxytocin, glutamic acid and aspartic acid, histamine, endogenous opioid peptides, taurine and alanine, 2-phenylethylamine, n-imidazole 4-acetic acid, and substance P. Here I want to give you little more information about GABA. That's why I put the star here. GABA is primarily synthesized from glutamate by the enzyme L-glutamic acid, L-decarboxylase, which we called as GAD. It is subsequently transaminated with the ketoglutarate by GABA-A, oxyglutarate transaminase GABA-T to yield glutamate and succinic semialdehyde. This is a little bit of the biochemistry about the GABA. Two types of GABA receptors have been identified in mammals, GABA-A and GABA-B receptor. GABA-A receptor, when coupled with GABA, induces a shift in membrane permeability, primarily to chloride ions, causing hyperpolarization of the neuron. You might remember the description given in the chapter Sedative and Hypnotics. This GABA receptor appears to be part of a macromolecule that contains addition to the GABA-A receptor, benzodiazepine and barbiturates binding sites, and the chloride ionophore, which is a chloride channel. So this is why GABA is located and work in the system. Here one more table is given. I have taken this table from the Lippincott peptide neurotransmitters. So you can read out the family of compounds and the number of amino acids they have and what the special character they perform. So now with this little background information, we will move on to our chapter, that is the antidepressant chapter. As you all know, in the current scenario or in the current way of life, the depression is one of the very, very known term or very, very known disorder. In everywhere you can find the people who are in the depression, or they feel they are in the depression, or the doctor diagnosed them with the depression and they are taking antidepressant drugs. Even in the younger age, it has been observed nowadays, even the kids, they are having the depression and they are taking the treatment. So depression is not just an English term where somebody got little depressed for something, but it's a disorder. And this disorder composed of the number of symptoms, and by that the very specific treatment is available, and it has to be taken very well in account, that it should not be undiagnosed, it should not be untreated for a very long time, because if it is like that for a very long time, it may affect the other areas of the brain and may cause more serious conditions in the later stages. So depression is the first thing. The depression has to be understood well, and then after that it has to be diagnosed well, and then it has to be treated well. So we should see now what the depression is and what the antidepressant drugs does. So we can define it as a major depression, because minor depression sometimes it's a time being, or it resembles with certain symptoms of depression, but actually it's not a depression. It's a certain momentary situation has created certain things, and that you are feeling like depression. But when the situation moves off, maybe there will be no symptom and sign for like that. So major depression we consider where the actually the disease persists for a long time, and we can consider this is a depression. So major depression is characterized by symptoms like sad mood, loss of interest and pleasure, because sometimes we have sad mood, sometimes we loss of interest and pleasure, but every time doesn't mean that you have the major depression, right? So it should be a kind of permanent state, or a long or a very very long time it remains in the person, right? Low energy, worthlessness, people feel they are good for nothing. This is a worthlessness feeling, right? Guilt, psychomotor retardation or agitation. Here, sometimes we have guilt when we have done something wrong, what we assume wrong, right? But doesn't mean that's a depression. Depression means when you have done nothing and you are feeling having a guilt in you, right? So like that guilt, psychomotor retardation or agitation. Agitation is very important symptom, because they are always agitated people. They for even as any small minor things, minor situation, they get agitated. Change in appetite or sleep, melancholia, suicidal thoughts, etc. So these are all very very important major sign and symptoms of the depression, major depression. Drugs which can elevate mood in depressive illness known as antidepressants. So here we are not claiming that these drugs are curing the disorder, but we are claiming that they elevate the mood. When the mood will be better, then the person can feel better, and the quality of life will be comparatively better. Now we'll see what these drugs comes under this category. We have reversible MAO inhibitors. You know, I have discussed in detail about the MAO and monoamino oxidases while discussing the sympathomimetic chapters. In that time, we have discussed how the MAO are used to metabolize the adrenergic neurotransmitters. So here we are discussing about the MAO inhibitors, because we want to save, or want to the adrenergic neurotransmitters more in amount. So in that case, we have to reduce the degradation of them. For that purpose, we have the MAO inhibitors. So first category is reversible MAO inhibitors. Under this, we have two categories, non-selective and isoenzyme selective. As you know, MAO enzymes, there are two types, MAO A and MAO B. So that's why selectivity is also very important. So we have non-selective first category, where we have the another subcategory, hydrazines. Hydrazines, another important category of this. Phenazine and isocarboxazide. Non-hydrazine example, trenylcypromane. So these are our non-selective drugs. In isoenzyme selective, we have MAO A selective. For this, we have chlorgelin and moclobemide. Moclobemide discussed in the anti-anxiety chapter as well in detail. MAO B, that is selegiline. Second class is tricyclic antidepressants. Very, very, very important class of the this treatment. We have subclassification as noradrenaline 5-HT reuptake inhibitors, imipramine, amitriptyline, trimipramine, doxepin, dothepin, clomipramine, all very, very much used drugs. Predominantly noradrenergic reuptake inhibitors, despiramine, nortriptyline, amoxicillin, robaxetine. Next category is again very important category, very important category, selective serotonin reuptake inhibitor, SSRIs. Under this, you have fluoxetine, fluoxamine, paroxetine, sertraline, citalopram, escitalopram. These are very, very used drugs. The last category here is atypical antidepressants. Again, a newer class of the drugs here. Trazodone, mianserin, mirtazapine, venlafaxine, duloxetine, teneptine, aminitin, and bupropion. So these are the drugs used as an antidepressants. We'll see about the MAO inhibitors, because when we are going to study about the MAO inhibitor drugs, we'll see what these MAO inhibitors are. MAO is a mitochondrial enzyme involved in the oxidative deamination of biogenic amines, adrenaline, noradrenaline, dopamine, serotonin. MAO-A, if we discuss about MAO-A, preferentially deaminates 5-HT and noradrenaline and is inhibited by chlorgelin moclobemide. Okay, distributed in peripheral adrenergic nerve endings, intestinal mucosa, and human placenta. Now, what about MAO-B? MAO-B preferentially deaminates phenylethylamine and is inhibited by selegiline. Distributed in certain areas, mainly serotonergic areas of brain and in platelets. Dopamine is degraded equally by both isoenzymes. Liver contains both isoenzymes. So first we'll see the first category, which is called non-selective MAO inhibitors. In this, we have two hydrazine drugs. You may remember about the isoniazid. Isoniazid is one of the core component for the antitubercular treatment. The another drug is iproniazid. Right, this is also belong to the hydrazine category. Later, it has been understood that iproniazid is very much utilized for the disproportionate elevation of mood, because it has some action like that. So it can this category hydrazine become one of the important treatment method for the depression. Its less hepatotoxic congeners like phenelzine and isocarboxazide and some non-hydrazine MAO inhibitors like phenylcypromine were used as antidepressants. The non-selective MAO inhibitors elevate the mood of depressed patients. Here, this is these drugs called as the hit and run drugs. Hit and run drugs. Why they go hit and move off. So hit and run drugs stay in the body for relatively short periods. That's why they call it as just hit and run, because they go, produce their effect, and they move on. But their effects last for 2 to 3 weeks after discontinuation. The return of MAO activity depends on synthesis of fresh enzyme. Means when the MAO activity will be resume again when the new fresh enzymes will be formed. Tissue monoamine level remains elevated long after the drug has been largely eliminated. The active metabolite of non-selective MAO inhibitors inactivate the enzyme irreversibly. So here are some important ADR for this class of drugs. Fatigue, irritability, tremor, insomnia, headache, dizziness, postural hypotension, dry mouth, syncope, blood vision, impotence, constipation. In case of the overdose, there are certain conditions like sweating, agitation, confusion, hallucinations, and mania can be caused. Hepatocellular damage, and especially with hydrazine. So, by observing the ADR after some treatment period, the choice of drugs can be modified. In case of antidepressant drugs, because they all are acting on CNS, so they have a lot of chance that they get a lot of interactions with various class of drugs. So that's why here in every class of drugs we have to discuss about interactions. In this interaction, about the cheese reaction. I discussed you about this when we were discussing about synthesis of dopamine and noradrenaline. So you know what is the role of the cheese reaction, because you need the tyramine from that. So cheese reactions, certain varieties of cheese, beer, wine, pickled meat, and fish yeast extract contain large quantities of tyramine and dopa. In MAO inhibited patients, these indirectly acting sympathomimetic amines escape degradation in the intestinal wall and liver. Reaching into systemic circulation, they displace large amount of noradrenaline from transmitter-loaded adrenergic nerve endings. Then what will happen? Hypertensive crisis or cerebrovascular accidents will be happening. These conditions can be treated by rapidly acting blocker, example phentolamine, prazosin, or chlorpromazine. These can be in alternatives for treatment. Another interaction we have observed when the patient is taking some drugs which are used for cold and cough remedies. So what happens there? They contain ephedrine or other sympathomimetics, right? In that case, also hypertensive reactions can occur. Reserpine, guanethidine, tricyclic antidepressants. What is the interaction there? Excitement rise in BP, and means if you are adding the reserpine, guanethidine, tricyclic antidepressant along with these drugs, then what will happen? The excitement rise in BP and body temperature can occur when these drugs are given to a patient on MAO inhibitors. This is due to their initial noradrenaline releasing or uptake blocking action. Means you can assume in this way, whenever you are giving certain drugs which are protecting these catecholamines from degradation, and your drug is also doing the same, then there will be more amount of catecholamines available, and they'll produce effects in high. Next is the levodopa. Excitement and hypertension occur due to increase in biological fluids, DA and NA, that are produced from levodopa. So that's the case because dopamine and adrenaline will be rising in the level by the levodopa, right? And your drug also does the same. So there will be high amount of dopamine and noradrenaline available. Another interaction is with the antiparkinsonian anticholinergic drugs. What happening there? Hallucinations and symptoms similar to those of atropine poisoning occurs. Barbiturate, alcohol opioids, antihistamine. What they do? Action of these drugs is intensified and prolonged. Respiration may fail. Another is pethidine. High fever, sweating, excitation, delirium, convulsions, and severe respiratory depression have occurred. So I hope you understood the pharmacology behind this particular class of drug. Now we'll move to the second one, that is isoenzyme selective, MAO1 selective. The selective MAO-A inhibitor possesses antidepressant property. Selegiline selectively inhibits MAO-B at lower dose, but these are not effective in depression. Another drug is moclobemide. Moclobemide to be an efficacious antidepressant comparable to TCAs, except in severe cases. And if you just check the video of anti-anxiety drugs, you can find the detailed pharmacology of moclobemide. By this, I would like to end up this part here. In the next part, we'll discuss two very important classes, tricyclic antidepressants, and SSRIs. Thank you for watching.